Welcome to the neonatal intensive care unit at Evelina Children's Hospital. Very proud to work here and glad to have you here today. We are a level 3 neonatal intensive care unit, which means that we take care of the most complex, most challenging patients. We take care of our local population of South London, which is a very deprived part of inner city London. We also take care of the children further afield from the whole of the south of England and of the more complex patients. Our workload is pretty much split for 3 different groups of patients. Babies who are born prematurely, babies who are diagnosed antenatally with complex difficulties, whether that's problems with their abdomens or whether that's neurosurgical problems or whether that's heart problems. And the third group are children who have problems around the time of birth, either infection or being starved of oxygen during the process of birth itself. Prescribing medicines for premature babies and for small children is an incredibly complex task, and deciding upon the medication that we use. Firstly, because we're more limited in terms of the amount of access. It's incredibly challenging to get a drip into a baby who weighs 500 grams. You imagine that the number of places that you can put a drip is limited, and these babies are often in hospital for 3 or 4 months at a time, so need numerous attempts at getting lines in. When you're putting a drip into an adult and you've got a nice big vein the size of mine, but actually when you're thinking of a baby whose whole hand is the size of the end of my thumb, then that becomes very much more challenging. Sometimes we have to shine a red light through the hand to highlight the vein so that we can see where we're going. Okay, so this young lady she's about 4 weeks old now.
Yep.
She was born at 24 weeks. She's one of twins. She's been pretty unwell. She's had abdominal surgery.
Yep.
She's needed quite a lot of support with her breathing. She was extubated finally and successfully for the first time yesterday.
Well done.
So absolutely. So she's now breathing for herself on CPAP, as you can see. She looks quite comfortable with that. The main challenge over the last week in getting over the abdominal surgery has been we're now trying to wean down her morphine. So we're trying to wean down the amount of sedation and analgesia that she's needing. But being on CPAP, she's not tolerating it particularly well, and we want to give her some sedation. A little bit of sedation, but we don't want to go back on her opiate.
So we're keeping off the opiates.
Trying to stay clear of the opiate.
You want something that's not too respiratory depressing.
It's not exactly.
Okay.
Exactly. She's at the moment intravenously. She's on parenteral nutrition. She's on replacement due to abdominal surgery. Replacement fluids. She's on a little bit of morphine. She's on 7 mics per kilo per hour. She's on some insulin. She's on a vancomycin infusion for a presumed line infection, but she's getting over that.
Okay.
So, because of that line infection, because of other things, we need to stop moving away from her line. It'd be quite nice to avoid intravenous sedation if we can.
So, something like chloral?
She's had abdominal surgery, so we can't give her anything orally. So we're stuck with rectal.
Rectal
chloral sounds like
work well.
Sounds like the best option that we have for her at the moment.
Okay. So, dosing-wise...
710 grams.
710 grams. We're looking at something like 50 milligrams per kilogram as a starting dose.
How's your mental arithmetic?
I think that's about 35 milligrams at 0.7 anyway.
Okay, you're better than me, you're a better man than me. Okay. Yep. So 35?
35, but don't write that yet.
Right.
We've got issues with the preparation. The smallest suppository we've got is 100 milligrams. Now, if Eve's going to be if Eve's going to be clever here, we can halve them, although they do have to be sliced long ways, but hard to do 35 milligrams out of 100, but we could do a half, which is 50 milligrams. What would that be on a milligram per kilogram basis?
50 divided by 0.71. So that's 70 milligrams per kilo. That seems...
That's all right, because you can go up to 100. So
what's a reasonable dose for this? So that's
that
50
should work
milligrams.
Perfect. 50 milligrams.
Yeah. Okay. Carbohydrate. Maximum.
Maximum would be 3 times a day. We'd have to be a bit more cautious if they were only just born, but we've got a little bit of leeway here, not in the first week.
Okay, cool. You happy with that, Eve? Do you think that will achieve what we need it to? Fantastic.
Perfect.
Okay, brilliant.
Thanks very much.
This child has been prescribed some chloral, and it's been prescribed 50 milligrams, and each one of these are 100 milligrams. So I'm going to try to cut this in half to try and be as accurate as I possibly can. There we go. As you can see, once it gets heated, it becomes quite soft, and it's not very easy to cut it in half. Now that I've got my half, I need to get some lubricating jelly, and I use that so that it's easy to insert in the child.
Okay, this young lady, she's she's the other twin from the baby we've just seen. She's 745 grams, she was 670 grams when she was born.
Okay.
She's 4 weeks old, she was born at 24 weeks. She's done really nicely, so she's having some time off CPAP, she's breathing quite comfortably, she's got up to full feeds, she hasn't had any surgery, things are very straightforward, she's starting to grow. Just going to get out of here by getting enough breast milk in. Mum's done fantastically well. She's got lots of breast milk for her. She's weeing and pooing. Everything's going really nicely. So everything's enteral. We haven't got any lines. She's already on her usual supplements. So she's on Citron, Abidec, folic acid. She's on caffeine as her respiratory stimulant, and she certainly looks nice and active.
Yep.
And she's been on, our challenge is she's been on phosphate started on the 30th, so she's been on phosphate for just coming up for a week now. And pretty generous doses as well. You can see her sodium is okay, we can cope with that.
Okay.
And we've got her phosphate up into a decent level.
That's good.
And her calcium is at a decent level. She's on 1.5 millimoles BD, so she's on 2 per kilo. That's a phosphate though, isn't it? So yeah. 2 per kilo of phosphate, which means 4 per kilo of sodium per day. And yet her alkaline phosphatase is still climbing.
That's really climbing, isn't it?
It's impressive. And that's over the period of 2 weeks. We can see on those bloods. So I think she's crossed our threshold for starting some vitamin D.
There's no point in pushing the phosphates anymore, is there? So
she's already in a decent range. So
I think
we need to give her some vitamin D. Okay.
A bit of alpha calcidol.
Yeah.
There's lots, so it needs to be prescribed by the right name. So
alpha calcidol. Okay.
I mean, you're going for pretty much a standard dose here.
Yeah, absolutely.
Now, it's a strange preparation in as much as it's all done in drops,
Right.
which in reality is the most inaccurate way of doing it.
Okay.
I'd suggest we just go for a standard dose of 100 nanograms. Nanograms, not micrograms, so 100 nanograms.
Okay. How does it come?
We could do it per kilo, but you'll end up with a horrible amount to give, which is almost impossible. And it's
Per kilo?
No, just 100 nanograms.
Right.
To start with,
How much is in a drop?
It'll get too complicated if we start going for if we could go for 70 nanograms.
Yeah.
It's almost impossible to draw up, and also the accuracy of the syringes just won't do anything with that, because I think even where are we? It's 2 micrograms in 1 ml. There's 20 drops. There's 20 drops in 1 ml. 1 drop. You want 0.05 mils.
Okay. Are you good at drawing at 0.05 mils?
Just about.
I mean, in reality, 0.05 on any of the syringes that you've got is very inaccurate. But luckily with this drug, it's got a very wide therapeutic range, so we'll get away with it. But it's not good for dosing, I have to say.
Okay.
But in terms of what you need to give, it's...
Do I write it up as vitamin D or alpha calcidol or 1-alpha?
alpha calcidol. There's so many vitamin Ds, it's certainly good one to do vitamin D. So alpha calcidol, 100 nanograms.
We'll write that out.
Write it out for once a day.
So we've got a nasogastric tube.
And I think with this, because of the calculation issue, in the last box, either yourself or I should write that it is 0.05 mils.
Right, so I can write that in your pharmacy box.
Yeah,
0.05
mils. Otherwise we will end up with problems.
Okay, and when do you want to give it? Tie it in with the feeds? So we're hourly at the moment, so we've got other medications at 12, 10, 8, 6, 12, another 6. So another lunchtime one, it's only a... Yep.
This child's been prescribed vitamin D, and in this case it's called alpha calcidol. It's been prescribed as 100 nanograms, which is very, very difficult to draw up in a syringe. The pharmacist has seen the chart, and the dosage is 0.05 ml, which I'm going to try and draw up in this syringe. And that is 0.05.
Okay, and then I got told in handover that she's been having desaturations with her feeding. We're concerned that the milk is coming back up and causing her to have problems with her breathing.
Okay, so reflux of some sort.
Yeah, we've already got. I really like physical solutions for reflux, so we've already got her head up.
Okay.
We've already. We're not in a position to start spacing out her feeds yet. She's on breast milk, which is the best thing that she could be on, but I think we need to try and have something to help her symptoms.
So we either go for something like ranitidine.
Okay. What were our other options?
I mean, there's several issues with ranitidine, I suppose, which I'm sure you're going to be put off. But there is alcohol in the liquid to start with, just to add to your woes from it. And also, I think the volume again is going to be something like 0.05 mil, so it's very, very, very inaccurate. So that's going to cause problems.
And it doesn't treat.
It probably doesn't treat anything.
And it doesn't treat reflux because it just makes acid things alkaline.
And we've already got an alcohol or a neutral stomach.
We've already got milk.
So in this age group, not much good, and a nasty drug anyway in this age group. So
those are other options.
Something like Gaviscon.
So to do these harm. So Gaviscon may help in terms of thickening the milk as well.
Mainly thickening. It is a thickener. It has got other properties, but in this age group, it probably is just a good thickener.
Okay. So
now this is where it becomes complicated.
I knew you were going to say that.
I know. Because of the amounts that we're giving here, you tend to mix up one sachet, so one infant sachet, in 5 mils. But then you only put 5 mils in every 100 mil of feeds. Now I'm sure we're not on 100 mil of feeds here.
No, she's on
6 mils an hour.
6 mils an hour every hour.
Mils an hour. Okay. So we need to just taper that down. So it's per 10 mils, it's 0.5 mils of that solution. So each sachet you're making up in 5 mils, and then you're using 0.5 of it in 10.
So we throw away the rest of the sachet, or do we make up more batches in one go?
On the units, I mean, generally we throw it away just because it's hard to store, but it can be kept for 12 hours. So it really depends what your fridge is looking like at the moment.
But I think if you're saying is you put that in 10 mils,
yeah.
Baby's having 6 mils of milk, what do you do with the rest of that milk once you've given 6 mils?
So the rest of the milk, I mean, it can be put in the fridge, but that's what we'd suggest at home. But on a unit like this, probably more trouble than it's worth in reality, and you probably just lose it.
You have to look at wastage as well.
Yes.
Because you'll be wasting, if you discard it, you'll be wasting
the
4
milk.
mils of one's milk.
So do you want to go down again? So okay. Well, I mean, we can
make it up in 5 mils and
to make it up in 5 mils and just take 0. We'd have to work that one out. But 0. Just about 0.3 mils. We'll work that one out so it's precise.
So what do you want me to prescribe on here?
Well, let's prescribe Gaviscon infant sachets. And write it up per feed.
Yeah.
And I think even I need to go away and work with how much feed we're going to give. Because of course then as the feed changes, the dose is going to keep changing. So we're going to have to work out exactly how to do this as we build up.
We can see that it's difficult to get a drip or a line in a baby when their foot is as the size of the end of my finger, or the hand is the size of my thumb. In her right forearm you can see that she's got a line. This is a percutaneous long line and has been inserted through a peripheral vein and sits in a large vessel somewhere near the heart. This enables us to give medication, parenteral nutrition directly into a large vein and safely. The difficulty is that we only have a single lumen for that. It's very difficult to get lots of drips into a baby of this size, and therefore we're left with a single lumen, and we have to put this octopus on the end of it in order to give multiple infusions through the same lumen. This has difficulties in itself in terms of working out compatibilities, in terms of the pressures that each of the pumps require in order to get the infusions to run through.
So the cases we've just seen have demonstrated some of the problems we have with formulations. Within the neonatal group, it's especially a problem in terms of the tiny volumes that we have to give. And when we're trying to draw up 0.0 or 0.00 something of a mil, one, it's very hard to do, and two, the equipment we've got to actually do it with is actually very inaccurate. So sometimes it's almost a guess in terms of what the children are actually getting. So that's not great for practice, but that's what we have to deal with. But also for suppositories, they come basically made for adults. Most drugs do come made for adults, and therefore we have to manipulate them. That might be cutting suppositories and cutting them lengthways so that you know you've got the drug in it rather than just having a blank end. It could be manipulation of tablets, but if you're only taking a small part of a tablet, you've got to know whether it's water soluble or not. Otherwise, it could all just be stuck at the bottom of the pot that you've mixed this in if it's not actually dissolvable and only dispersible. On top of that, if you have actually got a liquid, what else is in that liquid? There's lots of excipients. We talked about ranitidine having alcohol. Now, the metabolism of a neonate for alcohol is completely different to our metabolism, and they can't tolerate it anywhere near the same as we can. And therefore, it's something that we don't particularly want to give. So it's not only not having the right products, but even when there is a liquid to give, they may not actually be appropriate for the neonate, and especially for the premature baby. So it's important that all sorts of formulations are thought about when dealing with this small age group. And when you move on to IVs, exactly the same happens, trying to manipulate adult doses into tiny parts for children. And when you're taking a small fraction of an ampule and mixing it in a larger volume to give, the inaccuracy becomes larger and larger, and that is a real problem for practice. It's essential that when dealing with medicines for children, one, we choose the most appropriate, and two, it's a joint process between doctors, nurses and pharmacists to ensure that what we have got is utilised to its best potential.